Good evening, everyone. Welcome. Real Talk Menthol Moments with Thelma Craig, brought to you by the Colorado Black Health Collaborative. We're also supported by the Colorado Department of Public Health and Environment. This project started about 5 years ago, and we named it Tackling Menthol in the Black Community. As you know, a large percentage of African Americans, Blacks, people smoke, and they smoke menthol. And so we want to address that. We want to support the community, and we want to learn more about it. We want to bring special guests. Last month we had two smokers who are having challenges with quitting. But today we have Dr. Kamal Henderson. Dr. Kamal Henderson is a cardiologist, heart specialist with the VA Eastern Colorado Health Center, the VA hospital. He's assistant professor at the University of Colorado Anschutz campus. He has established a career as a clinician, scientist in cardiovascular medicine with a focus on cardiovascular prevention, cardiovascular outcomes, and cardiovascular health disparities research. He's currently working on a cardiovascular research project, and we're really excited to see the outcomes of that study and that research. And we're just so happy to have him. When we discovered that we had an African-American physician in this space, we jumped on him. We just reached out, said, hey, we got to have you on. We got to have you collaborate with the Colorado Black Health Collaborative. And it really has been a very beneficial collaboration. So welcome, Dr. Henderson. We are so glad to have you on. We're so excited. We just want to talk to the community about your clinic and about smoking cessation. So welcome and thank you.
Thank you. Thanks for having me. I appreciate it.
Okay, we're going to get right into it because we don't want to waste his time. He's busy. Remember, I named all the things that he was doing. And so we don't want to, take away his time too much. Plus, he has a little family. And so he has to get back to the kids and the wife. So, Dr. Henderson, thank you again. But
thank you.
About your cessation clinic, that smoking cessation clinic, and the types of patients you currently work with, and how do they get referred to your clinic?
Yeah, no, great question. So, the smoking cessation clinic that we sort of revamped at the Rocky Mountain Regional VA Medical Center probably started around 2020. So it was initially ran by Dr. Alan Prochaska, who was well known in the space of smoking cessation. And he unfortunately retired. So we ultimately ended up taking on that clinic and revamping it to make it much more transdisciplinary, and what I mean by that is within this particular clinic, we have clinicians that are pharmacists, MDs, as well as health psychologists that sort of implement a transdisciplinary approach to both interventions related to pharmacological interventions for smoking cessation, as well as behavioral interventions as well. So the patients that come to our clinic, they get both modalities, which actually, based on evidence, is much more effective together than just doing pharmacy alone or just doing behavioral therapies alone. So since I initially stepped in around 2020, sort of helped build up our clinic again with Dr. Prochaska leaving now, and it is a robust clinic at this particular point in time. We do have learners that are a part of our clinic as well. So we have people that come in, MDs to PhDs and et cetera, to learn how to do smoking cessation effectively, as well as to learn different strategies to just change behaviors of individuals, period. And it's been a pretty good clinic. So I think one of the questions that you had asked is, how do you get referred to our clinic? So if in our clinic, it's actually the majority of the referrals come from primary care providers within the VA Medical Center. So that's the caveat with our clinic. Unfortunately, it's only for our veterans, but unfortunately, a lot of veterans do smoke. So we're definitely busy. So we can get referrals from that standpoint, as well as patients can, if they smoke and they want to come in and be seen in our clinic, we can definitely set that up as well. And what we've decided, which actually has been very instrumental to us with our transition is actually we used to deliver this program in person, but a lot of people it's hard for them to drive in.
Right.
So what we were able to appreciate was when we, due to COVID, we were forced to transition to sort of telehealth interventions. Our show rates went up, so it was down about 50% prior, and then went up afterwards. And it's been great. I think the veterans definitely enjoy it.
Mhm.
We definitely have a solid team, and we implement evidence-based interventions that I think are instrumental for getting our veterans to quit.
Well, that's wonderful because we know veterans have experienced a lot of things like PTSD, isolation, PSTD, or PTSD, isolation, and a number of things because of the stress they were under, they may have been under. But large percentage of Black men smoke menthol and have a hard time quitting. What are the unique challenges that veterans have in quitting smoking, would you say?
Yeah, I would say, the challenges of not smoking or quitting tobacco is not necessarily unique to the veterans per se, but you did point out some few things that actually increases the risk of them actually smoking. And I think that's the biggest thing, right? So they at an increased risk of smoking from a myriad of things. One, you're right, the issues with war, as well as, it's funny when I have my veterans in clinic, and they used to say that in order for them to get a break, they got cigarettes, and while they served in the army and navy and et cetera. And so and there's been documentation related to that, actually, that was a way for them to get a break in while serving, and a lot of veterans started to smoke because they wanted that break.
Right.
And so unfortunately we're dealing with the remnants of that in our clinic. So, but I think the biggest thing is like anyone else, cigarette smoking is a form of release, of psychological release, and et cetera. And it lasts. It becomes difficult if you use it as a form of stress release. And then once you start those habits, it becomes even more difficult to quit. And then if you add on to that other psychological stressors in your life, it becomes
Mhm.
difficult. So
Mhm.
you're right from that standpoint. It is higher. We do find that, like anyone else, the smoking is fun, and it's a form of release, and it's hard for them to get past that.
Right,
And
right.
but we get them there.
I like that when you say we get them there because one thing I really like about you is when you came to present at one of our coalition meetings, your demeanor, your calm aura about yourself. And if I
Thank you.
smoked, I would be sitting in your office. Well, of course, I had to be a veteran, but I really like the way you're calming and the way you have an understanding approach and ideology about this predicament that folk smokers find themselves in, being understanding. So describe a high risk and a low risk, what a high risk and a low risk patient looks like at the clinic. And
Yeah, so that's a good question, and that definition is relative, right? But for us, we do have people I describe as low risk because they know they want to quit, and they actually have started to reflect on quitting, have a stop date, more than likely have already stopped, and just need some behavior tricks, hacks, and things like that that they can do. Maybe additional use of medications and et cetera, such as patches that can get them through. And those individuals actually do quite well, at least what we've seen when we refer them off to these electronic consults that you can do either at the state level, or we have one in our system as well, for which they don't have to necessarily be in the clinic or be part of our clinic to be involved with. But then we do have a high risk. And when I say high risk, these are individuals been smoking for 50 plus years. A pack a day is nothing, and they're not at that reflective point of view for which we do like our patients when they do come into the clinic, they at least are thinking about quitting.
yeah.
And then our good job is to get them from thinking about quitting to, all right, this is my quit date. And
Hmm.
then once they have that, and then we start getting them to, all right, well, these are the strategies that you can do. And so when I think about high risk and low risk, at least for the clinic that we've established here at the VA, I look at them that way. Those who are ready to go and
Mhm.
don't need much,
Yeah.
just need, all right, kudos to you. And then
Yeah.
those are like, buddy, I'm thinking about it. I'm gonna have to call you next time. We'll figure this out the next time
Yeah.
around. So
Yeah. And you said um, strategies. And what are some successful coping strategies your patients use to handle smoking? Name a few triggers. Um, yeah, to use to handle the triggers. Can you name some coping?
yeah.
You said you talked about the medication,
hmm
and you talked about the other system. What was the name of that system? You just mentioned it. And so, what are some other coping strategies that you can impart, to our listeners that they may be privy to?
Yeah, well, I think one of the biggest things that people first have to recognize, and this actually is part of the strategy, is your brain over time has become it has gotten to a point to need the substance, right, in order to function correctly. It takes around 11 seconds for nicotine to get to your brain and then start acting on your brain. And all that, if you've been smoking for 20 plus years, your brain is now rewired. And in order for it to function correctly, it needs this substance to perform. Without it, it's just not performing at its maximum. And
Mhm.
so I start there first, because once people recognize that this is it's a psychological thing now. Now your brain has rewired connections and need this substance in order to function. And then once you recognize that, then you can start diving into, all right, now these are the cues, right? So once you establish the behavior and then you establish the habits, and then people can start recognizing what their habits are, so we get some smokers that come in and say, every time I get in the car, I got to drive. And when I'm driving, I need a cigarette. And
Mhm.
so a strategy could be like, well, if you know that that is a cue for you, and that's what we call it, cues, uh, leave the cigarettes in the house. Make it hard for you to find. All right.
Mhm. Mhm.
And so you can do these different things that, you first just go through them going through what are the triggers for them. And
Mhm.
then from that, you can come up with better solutions, sort of just using, behavior therapy approaches to say, all right, what are better strategies that you can implement to keep
Mhm.
you away from those cigarettes? And then the
Mhm.
second piece with that is, I'm one that actually do favor the use of certain medications to help with the craving, because that craving is a lot. It's very intensive. And
Mhm.
so, no matter what you do, if that craving is so strong, that behavior, you're not going to be able to implement that. And
Mhm.
so, as far as coping is concerned, the biggest thing is just, walking through what are the triggers and cues for the patient. And then also working with them on just trying to change their motivation to do it. And so we have to find what is the motivation for them. And
Mhm.
for a lot of our veterans, it's just living a little bit longer. Don't want
Yeah.
to cough anymore, tired
Yeah.
of being out of breath and want to live life, and so that's what we try to help them do. So we let them see that first,
Right.
come up with a quit date, and then let's go through your triggers so we can figure out ways to go around those triggers when they come.
Mhm. I was thinking, I've heard this a lot, cold turkey. What rate of do you see in your patients just go cold turkey? Is that a high rate in your clinic that they just say, I'm gonna quit and stop?
Some people can do it. I'm not going to say that people can't do it. And we definitely have a lot of people who have that sort of those personalities that can do it.
Okay.
Um, but we tried not to do that approach. I mean, one of the things too is people say I'm just going to do cold turkey, but then they don't see us anymore in clinic, and we don't know what's happening with that patient, unfortunately.
Mhm. Mhm.
But I do feel that what's the sense of going through this process of trying to quit and going through all these cravings when we have tools that actually can help you do it much more effectively.
Mhm.
And so, but our goal is to we work with the patients in this clinic, and let them know, hey, we got these strategies, and we just give them a manual of approaches that they can apply,
Mhm.
and then work with them on where they at to try to apply those tools the best way they can. Because that's the biggest thing is I'm not doing it; is they're doing it, but we're
Right.
just coaching them.
Wow. I just saw across the screen 63.9%, I think, of Black folks have tried to quit, and I'm doing a
Hmm.
presentation next week, oh, no, next month with the Quit Line talking about quit attempts in the Black community. And so we're going to be talking about that. During our last Real Talk episode, we spoke with two current smokers, and one of them has been a smoker for over 30 years. And she mentioned that she doesn't know what life would look like as a non-smoker, which is why she doubts she would ever quit.
Mm.
In your experience, what are some um, of the reasons why people tell themselves that they can't quit smoking, and what advice you can give them? You know, for people who think this way. And I know you have to have them in the clinic, and like you
Yeah.
said, work with their triggers. But simply, what advice would you give them if they say they just can't do it?
Yeah, so at that point in time, really, that's when we start using sort of the motivational interviewing techniques and skills. And so, what I mean by motivational interviewing is really trying to understand what is a motivating factor for them, even if it's motivating them to smoke, right? And so, if someone says that I think you gave the example of it's a bit, I don't know how life will look like without quitting, right? I mean, without smoking, and don't know if I want a life without smoking.
Yeah.
And we just start from there, so tell me, like, why are you saying that? And there's usually a reason behind it. It's friends, and or the husband or their spouse smokes, and that's part of the form of their interactions with each other. That's probably the only time they maybe talk to each other. I don't know, but we we work through all those things, and just starting from there and understanding the underlying motivations. And then also, once you go through those things, you can start identifying things that they may want to help, that they may want to move forward with as far as quitting. And I'll say that, the goal with smoking cessation is not to say that a one size fit all approach to getting someone to quit works, because that
Mm,
is not the case.
okay.
All kinds of people have all kinds of reasons to smoke and not to smoke. Truly, the goal is to try to look at, size up people where they are,
Hmm.
understand what's making them do it, and then give them behavioral strategies to work around. All right, well, I can't quit. To, you know what, I'm tired of this cough. If I can get rid of this smoker's cough, I do it. And if that's the case, I say, hey, the smoker's cough go away within 8 to 12 months if you just stop smoking.
Yeah, and
Uh,
that's important
yeah,
too. Like, what are it can't. I mean, they can see improvement sometimes right away or within a few days if they stop
yeah,
quitting. They can see some improvement in their health, and how they feel. So, what are some of
yeah.
the things they see, in that timeline? What does that look like in about 2 weeks? The
Well, yeah, I would say, that craving goes away probably in a little bit less than a month. And then also, too, the craving linked to the habits, right? So if you're actually able to quit and you're constantly thinking about these cues and trying to stay away from these things, these social factors that are making you smoke, um, you now find something else to do at that time. Like, if you think about it, it takes around 5 to 10 minutes to smoke. If you're smoking a whole pack a day, 5 times 20, so you've spent so much time trying to smoke, it takes away time from other things. And I think that's the biggest thing that people really see is,
Mhm.
they feel a little bit better, right? They have a win because they now they quit this thing. It's hard.
Yeah.
It's really hard, but at the same time, they now have time and space to occupy that time, and that they were using to smoke. And I think that's the most important thing. But
Mhm.
yeah, over a month, that craving definitely goes away for most part.
Mhm.
That cough definitely resides or goes away within 12 months.
Mhm.
And then you start talking about, substantial improvements in risk, right? So risk of heart disease go away by 50% within 1 or 2 years. And then if you stop
Good.
smoking for 8 years, your risk factor for having a heart attack is the same as someone else. And so those are some of the motivating things that
That's
we
good.
try to get our patients to understand.
And that's really my second. it was after this question I had, but based on your research, why does smoking contribute to the development of heart disease? I mean, what?
Yeah, mhm.
Yeah, just explain that a bit. Why?
Yeah, well, there's a lot of things that came out, definitely in the basic science area and et cetera. We do know that smoking does change around the some of the biological aspects of the vessels that supply your body, right? So the blood vessels themselves, and it can harden them, and then it definitely leads to hypertension. So if you think about the effects of just nicotine itself and all the carcinogens in the tobacco itself, what you get is unfortunately an elevated heart rate, and that continuously doing that over time definitely can, ideally people should have lower heart rates.
Mm-hmm.
And it automatically starts increasing your blood pressure, and it increases your probability of actually developing diabetes. And
Mm-hmm.
so we have, elevated blood heart rate. It's okay. I mean, it's, ideally, you want variable heart rate, and that actually is a good predictor long term as far as good cardiovascular health. But when you start adding in high blood pressure and diabetes, those two combinations alone,
Mm-hmm.
we'll just say for Black men, hypertension, diabetes is approximately around 35%. Attributes of around 35% to their heart
Mm-hmm.
attacks. Just those two alone. And then you add in the smoking, you have about 50% of heart attacks could have been prevented from smoking that led to the diabetes, that led to the high blood pressure.
Mm-hmm.
And so that is how this knock-on effects, unfortunately, that's due to smoking kills communities and kills especially people of color.
Yep. And I was going to get to that. Um, you know, what are because of it is because of a large percentage of black smokes, particularly black men, and they have unsuccessful quit rates, higher unsuccessful quit rates. And I talked to you recently about that, and you said because of the menthol, it's harder to quit menthol, and so a large percentage of black smoke menthol because of that marketing early on. Cools and Newports and
Mm-hmm.
and all of those favorite things that really the tobacco industry really looked at. Well, they marketed manipulation, I think, and it was all about money. But now it seems like we have to really have people become aware that it is a social justice issue. It is
Yeah.
a disparity, in our community, that a large percentage of us are smoking and dying, from smoking related diseases. Let's see. So in the Black community, there are a lot of conspiracy theories and misconceptions about using nicotine replacement therapy, pills, patches, and smoking. What are some of the misconceptions you've heard, and what do you recommend the response should be to address those misconceptions about using those things? Because
Yeah.
we're a community that we have a lot of mistrust, with medications and whatever, a
Yeah.
lot of about medications in the community. And so I think sometimes that contribute to people not really wanting to utilize those methods.
Yeah, I find that actually interesting that you take one of the most harmful substances ever created, and we focus on um,
Good point.
these other substances that are trying to help you stop that substance that's the most harmful, right? I think, but we do have to meet people where they are, and if there is something that's a concern for them, then we just have to really find out where did they get that information. That's clearly misinformation, and then if we can get them to at least understand where that information came from and how is that impacting them as far as what are they doing, their strategies that they're implementing, then from there we can figure out the next steps as far as to how do we educate someone who's clearly been given misinformation. So, a lot the these medications, don't get me wrong, I mean every medication that you take, there's always a side effect potential there, and so I would never discount. I mean, one of the probably what we've noticed, aspirin is over the counter. Eat too, you take too much aspirin, you're going to be in trouble, right? But we give it to
Right,
everyone that
right.
comes in with a heart attack, and so there's a balance there. But the goal of these medications, the nicotine replacement therapies and et cetera, is to decrease the amount of harm that you're receiving every day that you smoke a cigarette. And so
Mhm.
we just have to be realistic about that. You
Mhm.
are harming yourself every time you smoke that cigarette. You're
Yes.
harming people around you every time you smoke that cigarette. If you have children, one of the most common things that get people started on cigarettes
Mhm.
is seeing their parents smoke. So now you're
Right.
starting multiple generational issues that's in your family, epigenetic issues now that's sort of transcending you to your children to their offspring. And
Right.
so when I step back and say, all right, hold on, we're talking about the harm and the impact that you're doing to yourself and the people around you,
Mhm.
and you're concerned about a little nicotine patch, you need to figure that out.
Right.
At the end
Right.
of the day.
It's about making sense.
Yeah,
Um,
exactly.
People with opioid addiction can receive the help them with severe cravings. Do you
Yes.
think help? Do you think help take similar medication? It will take similar medication, on that level, for severe cravings to smoke.
Yeah, so that's the whole point of a lot of these medications. So definitely the nicotine replacement therapy, the goal is to give you that nicotine, right? So you can decrease that craving. And then there's other medications out there, thinking about bupropion, et cetera, that it helps block the effects of nicotine in your brain. So you're not having that craving as large as you were before without these different medications. And I tell people all the time, especially when it comes to nicotine replacement therapy, it's actually not the nicotine that's the most harmful. It does add some issues to long-term health issues, but the thing that's killing people the most is all the carcinogens and things like that that they put in these substances. There's over 1,000 substances in one cigarette that you're
Oh,
inhaling.
wow.
And well, I would say well, it's up to around 700 substances. I'm sorry, 70 of them, 70 plus of them are active carcinogens that
Wow.
have no causes urologic cancer to lung cancer, etc. So so the goal there is to recognize, all right, if we had a chance to choose between this harmful substance and the cigarette itself versus the nicotine, we're going to choose the nicotine each and every time. And then once we get as being in the nicotine replacement therapy, so we try to get you used to the nicotine replacement therapy to help you out with the craving. And then we can take you off of the nicotine replacement therapy, the patches and the lozenges and all those things afterwards. But yeah, you're right. It's the same strategy as opioid addiction, methadone, and et cetera.
I
It,
wanted to mention that.
reduce
Yeah,
the harm.
reduce
Reduce
the
the
harm.
harm. We don't want you to pass away from heroin. And if that's the case, then we give you methadone. It's the same thing
Yeah.
here. But I would say that the addictions are definitely different, and one can definitely cause more harm than the other. So I don't want to make it an equivalent statement, but the strategy is the same.
So this is a little bit political because the FDA last year announced that they're looking at banning again because they've been talking about this. I think even during the President Obama administration about banning menthol in cigarettes, and that's really what most Black people smoke. Um, I know this is not scientific, but you think that that's going to cause a lot of problems in the Black community if they ban menthol? I mean, some people say it could be a criminal element happening, or and this is political, and I try not to venture and go into that, but what's your thoughts on that banning menthol? Just a few thoughts, because we don't want to rile people.
Yeah, well, I would say that they add a lot of nuances to these laws, right? So it's not necessarily technically banned per se just yet, and I know the FDA is considering banning it all out, which I think is ideally is a good strategy and approach. I would say that I have sort of two minds towards that approach, right? So there's a potential that it can impact individuals who are thinking about smoking, because menthol actually allows you to tolerate it. The flavored substances allows you to tolerate the smoke itself, right? To
Mhm.
inhale it, and
Right.
that the menthol itself the goal is to provide a cooling sensation that is
Right.
throughout your mouth and in your throat, so you can tolerate the substance. And so, I kind of have two thoughts. Some of my research points to people who want to smoke, they're gonna smoke.
Right.
just gonna,
Right. You're gonna find it.
let's just
Yeah.
be honest about that. If they want to, if the people who are already smoking, they're gonna smoke and they're gonna find a way to smoke. If you take the menthol out, fine. I'm just gonna do some regular tobacco and we'll call it a day. But I do see that it might be an intervention to get young kids and young adults
Hmm.
from smoking. And
Yeah.
I think that where the impact is going to be. And this will be something that will happen over time. We're not going to see immediate success with this. And I think the more and more we stigmatize it, the more and more we decrease it being a social norm, especially in communities of color. Because yeah, I remember I'm an '80s baby. And I tell you this all the time. And I remember as a child, and this would just give you a reference of the neighborhood that I grew up in initially. Um, as a kid in kindergarten, we can walk to the store and get cigarettes for our parents.
Right. I
Right,
remember.
that's a
I'm big.
social norm that
Mhm.
that has been created, and luckily for me, I didn't look at cigarettes as something that I wanted to do. Um, but that to me is the issue, right? Why do we have so many of these stores in our communities to begin with?
Right.
And it's so ubiquitous and easy to get the substance. And so, yeah, I like it, but I think it's going to get us there. I do truly appreciate the FDA is thinking about
Right.
equity and doing interventions to decrease the harm and impact that
Yes.
these practices have with tobacco companies and et cetera, the harmful impact that have done to definitely communities of color, definitely men,
Yes.
and definitely black men. So I'm all for it, and so I like the thought. I
I
like to
like
see the
to
results.
I do. And you mentioned youth. What do you suggest, or where can we start with reaching youth and normalizing smoking cessation? Because the kids are vaping. Some kids don't think that vaping has nicotine in there. Some people
Mhm.
started vaping because they said that will help them stop. So where can we start reaching youth and normalize so that we can normalize smoking cessation? Like how, I mean, I know that's kind of a social question, a construct, but
Mhm.
just what are your ideas on what can we do, to really reach our youth about smoking cessation, or not even start prevention? What
Yeah, that's a
more
really good question,
answer.
and I have to be honest. That's some literature that I have not dived into a lot, and so anything that I provide as far as that answer is concerned is just me thinking through logical approaches to address
That's
young
good.
adults,
Mhm.
and so I think the first thing is getting an understanding from young adults themselves of what's happening and why they're doing it, right?
Mhm.
And I think the unique strategy that the vaping companies instead of have done is they actually because nicotine is not necessarily regulated in these substances, they can hijack the amount of nicotine in these
Mhm.
substances with the explicit goal to get you addicted as soon as possible. And so
Wow.
the amount of nicotine sometimes in these vaping substances and et cetera is substantially higher than what you would get from a cigarette. The
That's what
overall
I
goal is
was
for
reading
you to
that.
come in, right? And
Yeah.
so and I think when it comes to young adults, you really do have to get reach them where they're at, right? And I think we all were young adults. You rebellious, you got to go through that phase in life in which your mom, she's not cool. Everything she says is not
Right.
is not meeting the point. But then also too, we have young kids out living in homes in which their moms are smoking, right?
Right. Right.
And so I feel that the more and more, at least from my perspective, that we can work with young adults to make this not a social norm, the
Right.
more and more we can actually impact young adults, right? And let's meet them where they're at as far
Right.
as these kids and if it's social media and et cetera. And what I've seen too with a lot of kids is they are at least these generations that I'm seeing now are much more aware of social justice issues.
I think so.
And this is a social justice problem.
Yes.
This is not cool.
Right.
There's a lot of things you can do that is cool that I probably would never understand because I admit I'm just getting older.
Hmm.
Um, but now don't make that cool.
Right.
This is
I
a
like
social
that
justice
answer.
problem.
I like that because it is a social justice issue. And when we first started this project, what we realized when we surveyed the community and talked to a lot of people, people didn't realize it was a social justice issue. They also didn't realize, the disparities in the Black community. They didn't understand that, this was about targeting the community so they can sell, so they will make money, marketing, manipulation, And so I think when you tell them it's a social justice issue, I think people are begin to say, "What? We were targeted. I mean, this was put upon us. And so
Yeah.
it's really a strain on our community." And Dr. Kamal, I really appreciate you coming on tonight. I could talk about this um, long periods of time, but I know you have to go, and I try to just do 30 minutes because on social media, we don't have a long attention span. We want people to listen and learn. So I really appreciate you coming on and speaking with us on Real Talk, and really all the support that you give us, during this project. And we are here to support you and how we can help you. But I think across the screen, we had a number where people wanted to reach, there's some veterans who want to really reach out and get in touch with you. They can. And so it's just important that the community know that we have you on the front lines, trying to support our community, with this issue. So we appreciate that and all the work that you're doing in cardiovascular health and prevention and, all those things. We're just so proud of you, that you are addressing this issue and that you are so full of information. I like your like I said, I like your calm demeanor, and so hopefully, that's what the patients are experiencing and helping them to quit. So we really appreciate the work that you're doing. Thank you so much
Thank
again
you.
for joining us on Real Talk Menthol Moment. So hope to see you soon.
Thank you. Thank you for the invitation.
Okay, bye.
Bye bye.